Okay. Good afternoon, everyone. આજનો આપણો વેબિનારનો ટોપિક છે રોલ ઓફ ફિઝિયોથેરાપી ઇન સ્પીચ એન્ડ સ્વેલોઈંગ ડિસઓર્ડર્સ, જેના માટે આપણી સાથે જોડાયેલ છે ડોક્ટર કરિશ્મા મેમ જગડ, જે સિનિયર લેક્ચરર છે એટ ગવર્મેન્ટ ફિઝિયોથેરાપી કોલેજ જામનગર. Ma'am is having more than 13 years of teaching experience, and also ma'am is teaching PG students since 10 years. Ma'am, I would like to welcome you.
Thank you, Dr. Kalyani. Thank you very much. And I very much appreciate the effort taken by Sri Harivandana College of Physiotherapy for continuing this physiotherapy education amid this pandemic. And thank you for this opportunity. Now, without wasting much time, let us start with the topic. I think you will need to allow me screen sharing.
Okay, ma'am.
You will have to enable the button that says
Screen sharing. Yes, ma'am, enabled.
Enabled, no? Okay, yes, done. Can you see the screen?
Yes, ma'am.
Okay.
Yes, it's visible.
Fine. So the topic that we are going to discuss today is impairment of speech and swallowing, and we are going to discuss the acquired impairments of speech and swallowing, because speech and swallowing are also affected in many of the congenital conditions. But the topic under discussion today is acquired impairment of speech and swallowing. Now, why is it so important to discuss the speech impairment and how it affects a physiotherapist or rehabilitation professional? Now, speech is a very complex function that requires complex coordination amongst neuromuscular and even sensory structures, okay, of oral cavity, pharynx, larynx, and the areas in the brain. So it is a very complex function, and it is not just a part of our communication, not just a method of communication, but it is a part of our identity. Okay, this is the part of our being self. Now, some of you must have experienced that sometimes when you try to lie to someone on phone, maybe your mother, and you got caught, okay, just because your voice inflection gave you away. So speech is a part of identity. Someone can recognize you just by the way you speak, and each of us speak differently, right? So speech is important, and in this topic, what we are going to discuss is that we will first discuss how to assess speech, the brief assessment of speech. Then we will discuss what are the different classifications of acquired speech disorders, what are its implications for physiotherapists, where can we help or where can we adapt. Then the swallowing disorder, also known as dysphagia, and the treatment of dysphagia from physiotherapist's perspective. Okay, let us have a look at assessment of speech. Now, when the patient comes to you and you find that there is some problem with his speech, or some problem with the way the patient is talking, or even the relatives may complain you that the speech has changed after so and so incident, okay, then your first role is to assess the speech. Only after you assess the speech, you know how to communicate or how to develop communication with the patient so that the rehabilitation program progresses. Okay, so in order to rehabilitate the patient, you need certain mode of communication with the patient. You have to establish. So assessment of speech plays an important role there. The first thing you do is that you listen to the spontaneous speech, and so you tell the patient maybe to explain his history, or how did this happen, or you know, the chief complaints, what problems, for what problems has he come to you. So that time you are just listening to his spontaneous speech, and you are paying attention to the spontaneous speech. So while the patient is talking or trying to talk, you pay attention and you find out whether the speech is fluent, whether it is non-fluent, where does the patient has problem, does he have problem in naming something, or does he have problem in pronunciation. If he has problem in pronunciation, what are the words, whether it is the lips that are moving less, whether he has problem with guttural consonants. Okay, so while the patient talks, your role is to listen, and listen carefully and analyze. Okay, next thing you do is that you ask the patient to read aloud. So provide something to the patient, maybe a newspaper in local language, and just ask him to read a paragraph of it. What are you going to observe when the patient is talking or reading is that observe the lingual consonant. Lingual consonants are the consonants which require the tongue movement. Okay, so like t, which is made with tongue, and the word that is used to assess the lingual consonant is yellow lorry. So you can ask the patient to repeat this word yellow lorry, or you can write it down and ask the patient to read it. For labial consonants like m, okay, or you can ask the patient to pronounce baby hippopotamus. So m, p, b, these are all labial consonants. Then guttural consonants, which require your tongue to touch the soft palate. So those are called guttural consonants like g, k. Okay, so you look whether the patient is able to pronounce these guttural consonants. Listen to the content and fluency of the speech. So when the patient is speaking, does he speak in normal rate? What is the melody? Is he speaking in normal melody? Is he using correct grammatical, you know, whether the sentence that he is forming is grammatically correct? The words that he is using, are they, you know, proper? So you look for the content of the speech and how fluently the patient is speaking. Is he taking too much effort to speak, right? Then you test the comprehension of simple and complex commands. So whether the patient is able to understand your simple commands like get up or sit down, okay, or hand me that. So these are simple commands, and complex commands are like put your right hand on your left shoulder. So this is a complex command. Okay, so you assess the comprehension of simple and complex commands. And after you have done this, you analyze the spontaneous speech, naming objects like a few common objects, pen, a coin, or an eraser or a paper. You can show them these common objects and ask him to name these objects. Okay, then test the repetition. Speak a word and ask the patient to repeat that same word or a same sentence. Then reading, and ask the patient to write if he is literate enough. So after you have done this assessment, you will be, you will be able to classify the disorder or the speech impairment into one of the two very common impairment problems. Okay, so these two very common impairment problems in acquired speech disorders are one, aphasia, and the second is dysarthria. These two are the most common acquired speech disorders. So we are going to look into these two individually. So let us first start with aphasias. So what is aphasia? And now imagine yourself going into some, you know, different place, maybe down south, okay, where people do not understand, say, English or Hindi or Gujarati. So you are there in some state of South India, and you find yourself you are unable to communicate with the locals. Why? Your oral cavity is normal. You can produce sound, you can chew, you can swallow, you can speak fluently the language that you know. There is no problem with your peripheral system. But what is the problem? Because there is no memory of that language, say Tamil or Telugu. Okay, your brain does not have any memory of that language. So it is not the problem with the oral structure or pharynx or larynx or sound production. It is just the problem that your brain doesn't have a memory of that language. Okay. So similar problem, this patient, I mean, you don't have an aphasia when you don't know an unknown language. You don't have an aphasia, but just to know that the problem is in the brain and not in the peripheral structures. Okay. So when the problem is with the brain, in the areas that are responsible for the production of language, you call it as aphasia. So the definition goes like this. Aphasia is an acquired neurogenic language disorder resulting from an injury to brain and most typically the left hemisphere, because 70% of individuals have their left hemisphere dominant and the speech areas are located in the dominant hemisphere. Okay, so 70% of the time it is the left hemisphere which is dominant where speech area is located. Aphasia involves varying degree of impairment in 4 primary areas of speech, that is spoken language expression. So speaking a language, okay. So spoken language expression, spoken language comprehension. When someone is speaking and you comprehend the language, so that is spoken language comprehension. Written expression, you are able to write what you are thinking. Okay, so if you are able to write, that is written expression. And reading comprehension, if you are reading something and you understand that, you are able to understand the meaning, that is reading comprehension. So aphasia affects these 4 critical areas of speech. Okay. Now let us briefly understand the physiology of speech so as to understand the different types of aphasia. Now this is a figure of brain, and you can see the area here, which is the 3rd frontal convolution. Okay, and this area is also called as Broca's area. The another big area that you see here, this is spread over the first temporal gyri, posterior part of the first temporal gyri, and the angular gyrus that surrounds the sylvian fissure. This area is called the vernix area. Okay, so vernix area is basically a comprehension area where you understand the meaning of the language that either you are listening or you are reading. Okay, so when you are reading something, this you can see that this vernix area is very close to the visual area, secondary visual area, and it is also very close to the auditory area, secondary auditory area, right? So when you listen someone asking you a question, what is your name? Okay, so where does it reach? The auditory, all the auditory impulse reaches the auditory area, from there to the secondary auditory area, and from there to the vernix area where the meaning of that words, the spoken words, is understood. Okay, after that is done in the vernix area, there are some fibers which connect vernix area to the Broca's area, and they are called arcuate fibers. Arcuate fibers, they form the connection between these 2 areas. Okay, so through arcuate fibers, the information reaches the Broca's area, and it is the Broca's area which designs the response. So if vernix area says that your name has been asked, it is the Broca's area who decides that, okay, then I have to say it is Karishma. Okay, so the Broca's area designs the output or motor plan. Now Broca's area does not directly command to the oral structures to move and to pronounce the name. It sends impulse to the motor area. Now this is the motor area of the brain, and here is the motor area for face. Okay, so Broca's area sends signal to the motor area of the face, and the motor area of the face sends signals down, and so our jaws, lips, tongue, everything move, and we are able to pronounce. Right? If it was a reading, if you are giving exam and you read a question, okay, so the question that you read is analyzed here. It reaches the primary visual area, through there to the vernix area. Vernix area will analyze and interpret the meaning of the question. Through arcuate fiber, it goes to the Broca's area. Broca's area now doesn't send signal to the motor area of face. Instead, it sends signal to the motor area of hands. And your hands move accordingly and write the answers. Okay, so this is how the Broca's and Wernicke's area are important. Now let us see what are the types of aphasia. So basically we can classify aphasia into two types, non-fluent and fluent. So when I say a non-fluent aphasia, the speech of the patient will be slow, the speech will be slow, hesitant. Okay, patient will take effort to speak. The vocabulary will be very limited, and if it is severe, the vocabulary may be limited to just one or two words. Like patient, whatever you ask him or whatever he wants to say, he would just be speaking baba or tata or egg bay. Okay, so the vocabulary is severely restricted. When it is mild or moderate, the patient may be able to say words and nouns, but not the other parts of the speech like conjunctions and all. Okay, so if the patient wants to say I want to drink water, patient may just say drink water. Okay, so when he says drink water, it could mean I want to drink water, or please give me water. Okay, or I have drank the water. Whatever is the sentence, he would be just saying drink water. So verbs and nouns. Okay, so the vocabulary is restricted, but whatever he speaks is meaningful. And because these patients with non-fluent aphasia have normal auditory comprehension, means they are able to understand what they speak or what the others speak. So they will be aware about their disability. They know that they have some disability with the speech. Okay, and they are easily frustrated about their disability. So that is with non-fluent aphasia. Fluent aphasia, the patient would be speaking fluently in normal rate, in normal melody, okay, but the auditory comprehension is severely impaired. So patient is not able to understand what he speaks or what others speaks. So what will happen is that though the patient is speaking fluently, sometimes the speech will be nonsensical. That is, there is no meaning to the speech. Okay, so patient may use inappropriate words in the sentence, or he may start discovering new words which do not exist. Okay, that is called neologism. Or he may substitute sounds, like instead of dishwasher, the patient may say wishwasher. Okay, so he may, and if it is very severe, the speech is fluent but completely nonsensical and meaningless. Worst thing is that because this patient have impaired auditory comprehension, they may not understand what they speak, and so they are not aware of their speech problem. They think that they are speaking completely fine. The problem is with the person who is listening. Okay, so they are not aware of their speaking problem. Now, non-fluent aphasia, there are two types. So if once you have categorized that, okay, this patient's speech is not fluent, so they fall into non-fluent aphasia. Now the next thing is sub-categorizing the non-fluent aphasia. So the two types of non-fluent aphasia, the most common two types are Broca's and global aphasia. Broca's aphasia, the lesion is in here in the Broca's area of brain. Okay, so what will happen? The patient's auditory comprehension is normal, but the patient has a slow, hesitant and limited vocabulary speech, or sometimes if it is severe, the patient may repeat the same words over and over again to each and every question. Okay, so that is Broca's aphasia. Global aphasia, will come to it later. Fluent aphasia, there are two types, conduction aphasia and Wernicke's aphasia. Now, if you find that patient is speaking fluently, but his auditory comprehension is also preserved somewhat, that means he is able to understand and he is also able to speak fluently, but he is not able to repeat what you speak. Okay, if you find such, like if you ask him to repeat, then he will not be able to repeat a sentence or a word, but he can speak fluently. He can also understand and follow your commands. Then the problem is with conduction aphasia. And the area of brain affected is the arcuate fibers here, connecting arcuate fibers. Right? So then it is conduction aphasia. When the speech is fluent, but auditory comprehension is severely affected, it is called as vernix aphasia. Okay, the problem is here in the vernix area, right? So fluent aphasia, most common is Broca's aphasia, where the speech is non-fluent but auditory comprehension is preserved. If the aphasia is fluent, auditory comprehension is also preserved, but patient cannot repeat or patient has problem with the repetition, it is conduction aphasia. And if the speech is fluent but auditory comprehension is affected, it is vernix aphasia. Okay, and when the severity of aphasia is so severe that patient is not able to either comprehend or speak, we term it as global aphasia. So global aphasia is not actually a type of aphasia, it is a severity of aphasia. So if aphasia is very severe, where it affects the auditory comprehension and the speech, then we call it as global aphasia. Now, even after so much of lecture, you are not able to classify the aphasia into any of this category. Don't worry, because these categories may overlap. And there are some other small categories also, but even these categories may overlap. It may so happen that when you first see the patient may have global aphasia, but with recovery, the patient may later fall into Broca's aphasia. Okay, so even during the course of time, the same patient may show signs of different types of aphasia. Right? So it is okay. So now, how do we come into picture? We as a physiotherapist, how do we come to picture? Now, if your patient has aphasia, he will have problems in following your command because he cannot understand what you speak, or he cannot understand what you have drawn or written. So he will have problem in following the command, he will have problem in learning. And if he wants to say something like, he may have he may have had a fall yesterday and he want to convey it to you, he may not be able to do that, right? So the main goal here in aphasia is to establish an effective communication, and that can be done only when you work closely with a speech and language pathologist. And for each patient, he will that speech and language pathologist or speech therapist will tell you how to establish the communication. But there are general do's and don'ts that you should always take care of. So that we are going to discuss today. Let us first look at the don'ts. Don't switch the topics quickly. If you're talking to a patient with aphasia, don't switch between two topics quickly. Okay, be patient, allow time to the your patient. Don't speak too quickly. Okay, when you are speaking, speak slowly and very clearly. Okay. Avoid talking to the patient in noisy environment because patient will be distracted and he may have problem in comprehending. Your patient who has aphasia is focusing very hard, he is trying very hard to comprehend what you are speaking. Okay, so he should not be distracted. So avoid noisy environment. Avoid talking when the patient is exercising or he is doing any other, where his focus is on any other thing, then avoid talking at that time. Avoid talking with more than one person at a time. So if there is a patient and there is a relative, then don't talk to both of them together. Okay, and when you are talking to the patient, look at him and talk, so that he knows that you are talking to him and he can read your expression, and that will help him in comprehension. Don't ask questions that require long answers, like how was your day yesterday? Okay, now that requires an elaborate answer. So don't ask such questions that require long answers. Instead, you can ask questions that requires to be answered in either yes or no. So some do's that can help you in establishing the communication is that instruction should be short and simple. So when you are giving instruction about exercises, try to make it short and simple. Okay, say show them the exercise and tell them 10 times a day. So that is short and simple. Okay. Give enough time to the patient to process the information. So be patient. Okay, when you have instructed or when you have asked something, be patient and give enough time for them to process the information. Don't keep on pushing them. Phrase the questions that can be answered in yes or no. Did you do your exercise yesterday? So either yes or no. Did you had a fall in last week? Yes or no. Okay. And use gestural facial expression. So use your hands, use your facial expression, use your voice modulation. Okay, when you want to emphasize on something, so use your voice modulation, then that will facilitate better understanding. Speak slowly in simple sentence, but be consistent with instructions. So when you are giving instruction, it should always be the same one. Okay, so when you are teaching the patient to walk or to rotate, then always give the same kind of instruction for the same exercise. એક જ exercise માટે દર વખતે અલગ અલગ instructions આપશો તો patient will get confused. So be consistent in what you are telling the patient. Okay, so this is all how you can manage a patient with aphasia. Now, remain calm and patient. Moving on to dysarthria. So now, dysarthria is the problem with the speech production mechanism. Okay, so it could be the problem with respiration, it could be problem with the larynx and pharyngeal muscles or sensation, it could be problems with tongue and lip closure. Okay, so dysarthria refers to a group of neurogenic speech disorder characterized by abnormalities in strength, speed, range, steadiness, tone, or accuracy of movement required for breathing, phonatory, resonatory, articulatory, or prosodic aspects of speech. Now, ever experienced, when you have a bad cold and there is a sinusitis, your voice changes. Or when you have a hoarse, or when you have a sore throat, severe sore throat, your voice changes. So these are the problems with speech production mechanism. Okay. So how to classify dysarthria? So remember the assessment of speech where we had been listening to the patient and we had been looking what problems does he have. So at that time, if you find that the patient's speech is hoarse, like gogro awaj, strained, patient is using too much of effort, and labial consonants are affected. So p, b, bh, they are affected. So then it could either be a spastic dysarthria of cortical origin or spastic dysarthria of corticobulbar origin. How will you differentiate? If these signs and symptoms are associated with contralateral hemiparesis, it is of cortical origin. But if they are associated with pseudobulbar palsy, then it is of corticobulbar origin. Okay, both are spastic dysarthrias. If the speech is slow, monotonous with abnormal separation of syllables, okay, and this such type of very slow and same, there is no voice inflection, the voice doesn't go up and down, okay, it remains at same level and patient is speaking very slowly, a, j, ma, re, so very slow monotonous speech with separation in the syllables, and that is associated with cerebellar disease, signs of cerebellar disease, and then that is ataxic dysarthria. If the speech is soft, monotonous, and the volume is very low, like the patient is whispering to you, and even then he gets tired. Okay, so like the volume is very low, and when he tries, he speaks very fast. Okay, so very poor volume and rushes of speech. This is associated with extrapyramidal disease like Parkinsonism. And if the speech is slow, it is called as hypokinetic dysarthria. If the speech is fast, it is called as hyperkinetic dysarthria. If the labial consonants, so which are the labial consonants? The one that you speak with your lips. So labial consonants are affected first, then later guttural, and then the speech has a nasal twang. Okay, naak mathi bolta hoy evo awaj ave. So nasal twang and a progression to total loss of articulation. These and associated signs of element weakness. So other cranial nerves affection is also there, and there will also be associated problems with other function, like the patient will have problems in a nasal regurgitation, કે હું પાણી પીઉં તો નાકમાંથી નીકળી જાય છે, or patient will have difficulty in swallowing or dysphagia. These associated problems આની સાથે હશે તો it points to flaccid dysarthria. Okay, now many diseases affect multiple sites, and mixed dysarthria can also occur. For example, multiple sclerosis, it affects cerebellum, it can also affect the cranial nerve nuclei. So that time we may find that it is a mixed dysarthria. Okay, what can we do? Now, here, first thing is that proper posture can help in controlling involuntary movement and abnormal reflexes. So sometimes if you just stabilize the head or support the head in a good posture, it will help to control the involuntary movement like tremors or titubation of the head. Okay, that is the first thing to do. Second is non-speech oromotor exercise, also called as NSUMs. So non-speech oromotor exercise are also called as speech supplementation exercise, and they are used to increase the speed and range of motion of tongue, lip, and general facial musculature. So how do you do that? You ask the patient to protrude the tongue, move it side to side 5 times, or protrude the tongue, point it to the nose, point it to the chin, and repeat it 5 times. Ask the patient to push the tongue to the inner cheek on the right side, then on the left side. Okay, patient can roll the tongue and then open and close the jaw, maintaining the tongue in that position. Ask the patient to produce labial sounds like pa, 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 ta, 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 ka, ka, ka. Okay, so repetitions of this. So these are all called as non-speech oromotor exercise. Then exercise to improve head control and sitting balance, general postural exercise that helps in head control, and respiratory exercises. So you can increase the strength of inspiratory and expiratory muscles by using resisted or strength training of the respiratory muscles. Incentive spirometer can be used, blowing into a water glass manometer, that is for expiration strength training. Okay, so these are the respiratory exercises that can also aid in dysarthria. Now, coming to the last topic is dysphagia. So, before we move on to the treatment of dysphagia, let us look at the normal physiology. So, what happens is that when you are chewing the food, you are making a bolus, so the food becomes semi-solid into the form of a bolus. Now, when the interior part of the tongue elevates and pushes the bolus on the posterior side of the oral cavity. Now, as soon as the bolus touches the soft palate, what happens is that the soft palate elevates and closes this is the nasal cavity, so that your food does not enter the nasal cavity. So it closes the nasal cavity, and the posterior part of the tongue elevates and closes the oral cavity, so food doesn't come out from the mouth. Okay. Now these two cavities are closed and food is in the pharynx. Now as soon as the food bolus comes in the pharynx and the sensory receptors are stimulated, what happens is that this epiglottis, you can see the position of epiglottis here. This epiglottis falls over the trachea and it closes the entrance to the trachea, and so the only way left for the food bolus is the esophagus, and the upper esophagus sphincter opens and allows the passage of food into the esophagus. Okay, and then through the peristalsis the food is pushed down in the esophagus. So this is the normal mechanism. What is dysphagia? Is the difficulty in swallowing liquid or solid food due to disruption in the swallowing mechanism from mouth to pharynx. It may lead to malnutrition and dehydration, aspiration pneumonia, compromised general health, chronic lung condition, choking, and even sometimes death. So it is a serious issue. How can we help? Again, postural alignment is important where the head and neck are completely supported. Supine lying is very difficult for the patient. So the most preferred position is either upright sitting with head and neck supported, or patient is not able to sit, then at least half lying. Okay. Then there are certain position of the head and neck which can help. For example, chin tuck will help in closing the trachea or the respiratory tract so that the food does not enter the respiratory tract. Then if patient has a unilateral problem or unilateral pharyngeal paralysis, soft palate paralysis, then what patient can do is patient can look to the weaker side. So if the right side is weaker, patient can look to the weaker side and swallow, so that the food will be pushed to the stronger side of the pharynx. Okay, so these are certain postural techniques. Then specific exercises to improve function of oral musculature. So again, lip movements or lip strengthening. You can ask the patient to purse the lip and hold what to say, the candy stick, okay, between the lips. So that lip strengthening exercise, and tongue movements and tongue strengthening. You can resist the tongue with tongue movements with that candy stick. And then jaw closure and side to side deviation, opening, closing, and side to side deviation. Then blowing, puffing, okay, holding the air in the cheek. So that is exercises for the cheek that you can give, that can be used for strengthening this musculature. Then food presentation. Semi-solid food. Swallowing the semi-solid food is easier than swallowing liquid or hard food. Okay, so you can start with semi-solid food, and the food, patient's favorite food. Okay, it will facilitate the smell, the taste, and the texture of patient's favorite food will facilitate in swallowing reflex. So you can start with his favorite food and gradually progress to other foods. Now, when patient is trying to swallow, you can provide verbal cues and ask the patient that chew slowly, chew perfectly, so that it is easier to swallow, or tuck your chin while swallowing, okay, or press your throat hard while trying to swallow. And then massaging the cheek. So you can massage the patient's cheek or ask himself to massage, so that there are no food residues between the cheek and the teeth. Okay. Then teach him resisted sucking. So thick liquids like thick shakes or slushes. Ask the patient to suck those thick liquids with a straw. So that will strengthen the oral musculature. And stroking on the neck or vibration on the neck can also help in facilitating the swallowing mechanism. Okay, so that's it for the today's lecture, and thank you for your attention. Thank you, Kalyani, for paying so much of attention.
Thank you so much, ma'am, for your such an valuable information which you have given to our students. I would like to thank you on the behalf of an entire Harivandana team. Thank you, ma'am.
Okay, welcome. Close.